presentation. So I'm going to turn it over to Zahava to begin her presentation.
Okay, so thank you so much for having me today. There's so few people here. I think we could be very informal. So if people have questions, you can just feel free to jump in and interrupt me at any time. We don't have to save them to the end unless you're online, and then in which case we'll check the chat box at the end of the.
I'll go online just so I can see what's going on.
Yeah. So the topic of today's discussion is shared decision making in diabetes, and the focus is going to be. So it's basically talking about a project that I did with open funding, and for today's talk, I'm going to have a couple of slides on the implication for education and practice, specifically for pharmacists. So just acknowledgement slide, again, the funder is Ontario Pharmacy Evidence Network, although at the time it was not called that. It was still called open, but it stood for something else. In institutions.
Sorry, that's my husband.
That was not me. In terms of institutions, so as Lisa said, I'm adjunct at Ryerson University, and I work at the Ontario Pharmacists Association, so that's my disclosure. And we partnered with Benting and Best for this project. And of course, the project that I'm presenting today is part of a team, a larger team, and these are the team members that were part of this project. Okay, so what am I going to do today? I'm going to talk to you about the background, a bit about background of shared decision making, tell you an overview of the project, what we found, and then finally end off with some implications for education and practice for pharmacists. So you know that there are 8% of Canadians have diabetes, right? So roughly 3 million Canadians have diabetes. We know this is a growing chronic disease area. There's a lot of money being spent on diabetes care. And when we were brainstorming on possible ideas of what we wanted to do, what could we look at in terms of chronic diseases, we thought diabetes would be a good area. We're also interested, and I'm also personally interested in patient engagement. And part of that is patient engagement, especially when we're looking at direct patient care with clinicians, shared decision-making comes up a lot. So I thought, well, wouldn't it be neat if we could combine diabetes care with pharmacists and shared decision-making? And so Laura McKellen and I and Lisa started discussing it, and we thought, well, maybe there's something there. Maybe we can put together a proposal and see if we can get funding for it. And that's kind of how it started. And as we started doing a little bit of digging around to see what kind of supports are out there for shared decision making, we wanted to look at decision aids, because is one way to support shared decision making with clinicians and patients. And we found that the Mayo Clinic actually had a decision aid for diabetes that was created, and but it was designed for really physician and patient use, not for pharmacist use. So we put together a proposal, and we were fortunate to get funded, and we moved forward. But I guess before I move forward, does everybody know what shared decision making is? Good.
I want to know what your definition of it is.
Okay, so my question to you is, how would you define shared decision making? And then I'll tell you how we defined it. Oh. That's the way I was going to start off. So if I say shared decision making to people, would you know? So I think at least one person, you're practicing pharmacist, or yeah. So is this a term that you're familiar with, that you would have learned in school or not?
I'm familiar with it. I wouldn't have learned it in my undergrad pharmacy education, no.
Okay, so we didn't think so either. I did some digging in the last couple of days to see if the curriculum has changed. I'm not a pharmacist, I should say, so I wouldn't know if they were doing this 10 years ago or 15 years ago, when I would have maybe been in a pharmacy school. But I did some digging, and I saw that. Sorry. That's okay. That sounds really scary.
Okay, I muted myself.
Okay. So I did some digging just to see where the curriculum is at U of T right now, and we found that there is actually a course on diabetes. It's an elective course, and they do talk about shared decision making a little bit. So probably I would say the vast majority of pharmacy students don't really get education in this area. Okay, but the way we defined it for our project was an approach where the clinician and the patient share this available evidence when they have the task of making a decision. And basically the patients are supported to consider different options available to them in order to achieve a preference of how to move forward. So that's our definition. And then we went further to operationalize it by saying there are basically 3 steps that have to happen. The first is there has to be some kind of introduction of choice to the patient. The second step would be to describe the different options available to the patient. And finally, to help patients explore preferences and ultimately make their decisions. So that's the way we operationalized it, and that's the way we designed the interview questions for the pharmacists, which we'll talk about the methods in a second. Okay, so next, any questions? Okay, so based on the literature and the discussions we had with Bantang and Best and the team, we came up with,
Sorry, I do have a question. Can you comment a bit on, we talked about the shared decision making, what it is, but that the extent of acceptance of this as a definition? Like, we didn't just pull this from the air in a sense, but lots of disciplines and.
Yeah, that's a really good point. We actually did struggle with this for a bit, like as a team. We're like, okay, what definition should we use? There's so many definitions out there, and we went with Owen's definition because it seemed to be that was foundational in the literature. And also we like the idea that he or she, I don't even know, I should know that, operationalized it, right? And so it was not just about a definition, it's how do we operationalize it in practice? And so we really, as a team, felt that this was something that made sense for pharmacy and made sense indeed for, if we're going to look at supports for shared decision making and creating a decision aid, this definition would make sense to us. Okay. So research questions. So we had two. The first was we wanted to identify any barriers or facilitators to implementing a shared decision-making model within pharmacy practice. And the second question was to really explore the application of an existing physician patient diabetes decision aid, which I mentioned before. The Mayo Clinic came up with the diabetes medication choice decision aid, and see if we could use this for pharmacists and patients. So it's really testing an existing decision aid to see if there was scope to have uptake within the pharmacy profession. Yeah.
Sorry, can you also just talk a bit about the Mayo Clinic and their decision aids?
Right. So Mayo Clinic has a host, I guess, a host of different decision aids. This is something they're very skilled at. If you go to their website, and actually, I have the website on the next page and I'll show it to you. If you go there, you'll see there's for different disease areas, and they're very rigorous in the methods in which they develop their decision aid. So as with any kind of tool, some are kind of ad hoc and some are more rigorous. I would say that the Mayo Clinic develops their decision aids in a very rigorous methodology, which includes like interviews with not just clinicians, but patients as well. And we were, as a team, very impressed with the way in which they developed their decision aid. And actually one of our team members was from Mayo Clinic, and he was able to really help us understand how they developed their decision aid and potential implications for pharmacy. So, any other questions? Okay, so as I mentioned before, we decided to do qualitative semi-structured interviews with a convenience sample, and we wanted to look at community pharmacists, both that were located in urban and rural locations. We wanted to have a nice mix, and we also wanted to look at pharmacists that were certified diabetes educators, as well as those that were not certified diabetes educators, to see if there was a difference in their understanding of shared decision making and also their understanding of the tool, of the decision aid. In order to assess whether a pharmacy was located in a rural or urban location, we used a Rurality Index for Ontario. And I'll talk a little bit about that in the results section, but you'll see that there's a range on how rural or urban you are, and we just wanted to make sure we got a little bit of spread. I have to say we didn't get a huge spread, but again, we focused in Ontario, so yeah, we tried. And in terms of analysis, we used the thematic analysis to interpret the interview data, and we used descriptive statistics for participant characteristics and also to present the Rurality Index scores. Okay, so this is the decision aid that came out of the Mayo Clinic, and the website is at the bottom there. And you'll see there's actually 2 slides on this, that there's a number of different criteria that the physician would go through with their patient. So across the top, you'll see weight change. So the drugs are listed underneath, and they would discuss the implication of weight change with each drug with their patient and assess how important weight change was to their patient. The second was low blood sugar, third was A1C, and finally other considerations. So those are 4 topics the physician would sit down with the patient and discuss with the patient to see the level of importance those issues were to the patient. And then the next, so it's like the pamphlet, we can fit it on one slide. So it also goes through daily routine, daily sugar testing, and cost. So this is what it looks like. So basically they would print it out, and in the office, the physician would sit down with the patient and go through these items with the patient and ask them for their opinions about each of these different items. Okay, so in terms of results, we had a total of 16 participants in the study, the majority of which were female. You'll see that they provided a number of different services, including MedStrack and MedStrack for diabetes and smoking cessation. We had a mix of pharmacy owner, full-time and part-time staff, and a little bit more than half were certified diabetes educators. So a pretty good mix. And in terms of urban-rural, so if we look here, so the way it works with the rurality index is the closer it is to 100, the more rural you are. So our spread was from 0, which is like urban, all the way to 34, I believe it was. So we had a bit of a spread, but not all the way up to 100. So not super rural, but we did have some variation in location. So it wasn't all like center of Toronto kind of city base.
I think it's hard in Ontario to get really rural.
It was hard. We tried, yeah.
Can I ask the one that hit 34, where, I mean, like you don't have to say the opposite of the location, but like approximately what size town that is, or just out of curiosity?
I don't know offhand.
Okay, I can
I'm
just Google
sorry.
it. No, that's okay. Keep talking.
I don't
I'm just
know.
curious.
Yeah, that's a good question though. I don't know offhand. I'm trying to think. Yeah, I don't.
Yeah, no.
I know where it is, but I don't know what the larger location would be, so I don't want to.
Yeah, no.
Okay. So what happened was, in terms of recruitment, is we started recruiting. So we recruited through OPA, the membership list. So again, we restricted it to Ontario Pharmacy, the Ontario Pharmacists Association membership. So, and we sent out a mass email to everyone. And then we started calling people within certain postal codes to see if we could increase our rural representation in our sample, because we found that, of course, we were getting more urban pharmacists applying or wanting to participate. Okay, so when we look at the major themes that emerged from the interview data, there were a number of themes or buckets that came up, right? So the first was, we looked at pharmacists' understanding of shared decision-making. We also looked at their use of shared decision-making in practice, overall training. So whether having a certified diabetes educator, like CDE versus non-CDE, whether that made an impact. And then finally, the fourth one, as related specifically to shared decision-making, is implementation barriers and facilitators. So those first 4 are related to the shared decision-making in general. And then the last 3 are really specific to the decision aid that we were assessing. So there are 2 parts of the interview. The first part really focused on shared decision-making. The second part, we presented the participants with the actual Mayo Clinic decision aid, and then we asked them questions based on the decision aid that was in front of them. And so based on that, we asked them questions about workflow, like how this would potentially fit within their workflow, what any potential limitations they saw of the decision aid in practice, and where they thought we could improve on it if we were to implement it within practice. So when we're looking at the results specifically for shared decision making, we found that the majority of our participants were really unfamiliar with most of the aspects of shared decision making, with exception of describing options to their patients. They were really good at describing options, but they didn't speak about it in terms of shared decision making context. Like, so if I asked them to describe to me what their day-to-day was, like how, if a patient came to you with diabetes, what would you do? They described to me that they were describing options, but they didn't understand that that was really part of the process of shared decision making. And And then finally, they talked about some barriers of implementing, after we explained to the pharmacists, okay, what is shared decision making? Because we didn't realize, I think when we first went into this, that a lot of pharmacists wouldn't even know the term. And then we realized after the first interview, okay, we have to start defining what shared decision making is to them. And we had a bit of a discussion about that because we thought, well, methodologically, we might be biasing. Like, we're telling them the definition, right? Like, we want them to really come forward, but some of them were so lost that we couldn't really have the interview without defining it. So we're kind of a catch-22. So in the end, we did define it for them. We asked some questions without defining it, and then eventually later on in the interview guide, we would say, okay, this is kind of what we mean by shared decision making. This is how we define it. And at that point, they were able to identify, oh, well, if that's what shared decision making is, well, these would be some potential barriers. They included time constraints because they thought, well, this is kind of a lengthy process to go through, especially at the counter. Like, I would have to take them to counseling room or something. Like, there's no time to do it right at the counter. The other thing was a lack of patient willingness, because they felt that a lot of times patients would come to them, they already have a prescription in hand. This discussion may have, or hopefully already happened with the prescriber. So the patient didn't understand why they would be having these discussions with their pharmacists. And finally, lack of collaboration with other healthcare providers. So, like, if they were to have this conversation with their patients, and then it resulted in a change, prescription change, or something that needed to be changed, and then the pharmacist had to call the prescriber, that there was that kind of lack of collaboration, right? Because they had already, the prescriber already made a decision to prescribe that particular drug. Although this is not unique to diabetes or to shared decision making, I think this is something pharmacists probably would experience regardless, right? Okay. And then with regards to the actual decision aid from the Mayo Clinic, most of our pharmacists thought that, yeah, it could really be implemented within their workflow. And they thought the strengths of the decision aid included its comprehensiveness, the fact that it was really easy to understand and it was relevant to their practice, as well as they felt that it could really help them facilitate conversations with their patients as a guide. But they also said some of the barriers might be the lack of space. So they're like, where are we going to put these decision aids? Like, do we have to have more printed pamphlets? Because I don't have space in my pharmacy to have more pamphlets out. And also the lack of time was an issue. To actually sit down and go through those 6 different criteria with their patient would take a really long time. So what did they say in terms of, okay, if we were going to implement this in pharmacy practice, what are some things that we could improve? So first of all, one of them, I thought this was really interesting because it's something I never even would have thought about, is what about pharmacies that don't have the ability to print in color, right? Like, it's a very practical issue, right? And I would never have thought about it. Like, you know, I work in an office, so for me, it's like I have a color printer, I just press print, it's there, right? But you know, so when we think about it, it's like, okay, so what if I don't have a color printer pen? If this isn't black and white, it's not going to look as nice. Or even like the ability to have it electronically. Like, maybe this is something that could be reformatted to use electronically on a tablet or whatever. The other thing people really honed in on, we knew as a team already that this was going to be an issue, was cost. Because cost is not so much of an issue in Canada, because most of the diabetes medications are already covered for. Not for everybody, but the majority of patients are not thinking about cost when they come to get their drugs. So it was just reframing that, maybe to be more reflective of the Canadian context and the Ontario context. And then finally, there was one area that a couple of people had issue with, was the way in which hypoglycemia was described. I think it was more of the American way and the Canadian. There's some differences in the way there are some differences in way things are described in the U.S. versus Canada, and there's also differences in drugs and the way in which the drugs which drugs are available. So we would have to update that, and that was something they noticed right away. And we already knew that was going to be something that they highlighted. Some other interesting things that came out of the interviews were that participants really get the difference between guidelines and decision aids. So a lot of them, when we were interviewing them, said like, so like, you know, do you use decision aids in practice? And they say, oh yeah, like we go to the Canadian Diabetes Association all the time, and there's so many good guidelines there. And like, so then we had to have a discussion with them about, well, a guideline is not a decision aid, and the differences about that. So pharmacists were really good at getting resources they needed for their patients. Like they're like, oh, we print handouts for a patient on diabetes from this website, educational pamphlets, but it's not the same as a decision aid. So we thought there was a bit of a gap there and maybe an opportunity, like an educational opportunity. And then some participants didn't really understand the purpose of how to implement the purpose of it and how to implement it within practice. Like some of them were very confused because they were very focused on the fact that they were already getting this information from other websites and educating their patients, and it was hard for them to see the distinction between educating patients in the realm of, now looking back at it, I would say compliance. Like they understand that patients are more compliant when they understand the reason for why they're taking the medication, that they really get that, but they don't know how to separate that understanding from the use of a decision aid, like the difference. Okay, so what are some of the implications for education and practice? So what we learned was overall that there is scope to apply shared decision making or the shared decision making approach within community pharmacy. And there are benefits, there were benefits seen by participants to using this approach, and also that it could be facilitated with decisioning. So many of our participants thought it could be beneficial, and also thought that, yeah, you know what, this decision aid could actually help me in my practice. But ultimately, education of pharmacists in this area is needed in order to implement it within the pharmacy, with community pharmacy context, and also to help its integration within the workflow of pharmacy, because some pharmacists, some of them thought it could be integrated really easily, while others were struggling to see how they would fit it into their time and their workflow, which is why when we were discussing this, we thought, well, the MedCheck for diabetes may actually give a really good opportunity to integrate a shared decision-making approach with the decision aid, because it's already so structured, and to implement like a little layer of decision aid or shared decision-making within that context may be a really nice way to transition them into using this approach. So moving forward, what are some things, if we were going to move ahead with shared decision making and decision aids, what would we need to do? So first of all, in order to be successful, pharmacists would need resources, including time and space. And I think this applies to any additional clinical service that pharmacists are applying to, are going to apply within their practice. So regardless if it's diabetes or asthma or whatever, we know that pharmacists are overworked. And I think it's also tied to optimization of other staff members, right? So using their technicians, if they have technicians, and not all pharmacies have technicians available to them. So it's understanding the limitations that pharmacists have within their pharmacy. And also the idea that pharmacists really need to be recognized as part of the patient circle of care. And we heard this quite a lot, like, you know, like that either the patient themselves doesn't recognize the pharmacist as a healthcare provider per se, the same way in which they see their physician or nurse practitioner, or the way in which the prescriber sees the pharmacist. So they're not often looped in. They don't often have all the data or all the tests. They don't have the information they need. Yeah.
I didn't want to interrupt you. I'm just putting my hand up whenever you're done.
Oh, that's fine. No. Sorry.
No, I mean, just even listening to what you're saying, I also think it's, you know, this study was it's unclear as to what the role of the pharmacist is in the whole shared decision-making process. So if they've already had some parts of the discussion with the prescriber, is the pharmacist there to reinforce? How does the pharmacist know what's been done? How do they align their conversation with another prescriber? Is it good to have these, what are these conversations like if someone's already started on therapy, but you're trying to reinforce continuing to take therapy over time, like you're revisiting something after someone's been on something for a while? In the concept of when we think of deep prescribing, like there's always, that patient is always making a decision to stay on a medication as well, not just even start it. So all of these things, it's like how it was very murky, I think, and
it was.
There was so little experience that the pharmacists felt they could bring to two of the three components of the process that it highlighted such gaps.
Yeah, there were a lot of gaps. And I think, I remember one interview participant was like, well, why am I even, these are conversations they should be having with their prescriber. Like, by the time they come to my counter, they should have already had these discussions with the prescriber. So, like, that's not really within my scope. And even if I would have these discussions, they're not going to be open to having these discussions with me because they don't see me as having that role, right? So,
well, and the pharmacist doesn't see them as having that, him or her as having that role either. So then what do they're, it's how, what part of all these discussions should they take on? Which I think was part of our question is how can we figure out where the best, how can this be best placed within the pharmacy environment?
yeah.
Anyways.
Right, so circle of care. So we talked about that one. And the other two things that were left were that we saw that pharmacists really need to understand the concept of shared decision making, which they didn't at this point, and ways in which they could really integrate it into their workflow. So it can't just be dropped into their laps. Like, it can't just be an add-on to MedCheck as it is right now. Like, to do that would be really premature and actually, I think, unfair to pharmacists because they wouldn't be prepared. They just wouldn't. So if this is something that we think is important, then we, like the pharmacy profession, educators, have to start educating pharmacists in this realm, especially as we move away from dispensing and more into clinical services. I feel like this idea of shared decision-making, patient-centered care is going to become increasingly more important as we move away from dispensing. And then I think there'll be more opportunities for pharmacists in this area once we see more traction in the clinical services. And finally, like, I think this was just a preliminary study. It was, only 16 interviews. I think it was good. It gave us some foundational exploratory work, but I think future research will be needed to really determine whether a modified decision aid. So basically, the next step would be modifying the existing Mayo decision aid and testing it within community pharmacy and see if it actually works. That would be the next step. So, thank you, and I'm open to questions now.
Let me I'll come down and check. Yeah, do the chat. Yeah.
I'm going to let you do that because I don't want to accidentally alarm to go off or something.
As you can see, I've already had lots of technical difficulties just even during this thing. But yeah, it'd be great to hear what Della.
So you used exactly the Mayo Clinic decision-making tool.
Yeah.
So, okay.
We didn't make any changes. We said this is what it is. It was designed for physicians and patients.
Mm-hmm.
Do you think there would be application in the pharmacy? If so, what would you change?
Okay. So, because I'm just wondering if at the time of prescription, they've just seen the physician, whether that's maybe not the time. Maybe it's like follow-up, like a follow-up type of tool, like if they are having challenges, maybe maintaining their blood sugar levels, et cetera, maybe that, I don't know, I'm just thinking, like, is that where a decision-making tool for pharmacists?
Also, you might not know how the drug's going to react to that particular person, like, right?
Yeah.
So maybe weight gain is something that's very important to the person, and they put them on a drug that they didn't think would cause weight gain, but then it did, and then they stopped taking their medication. Pharmacists trying to figure out why aren't they complying with their medication, and then it comes out, and then at that point you could pull it out and say, like, well, these are some of the other things, like, let's look at the different options, right? And it could be.
Yeah, I mean, it's that weighing of values and preferences. So
and also in that situation, Della, I'm trying to think, like, there's something about the, I was thinking a lot about what you're saying too, Lisa, so I'm going to try to bring this together. The pieces of information that a pharmacist is going to bring to the table when they're trying to help them with the shared decision-making model. When a patient has come from a physician, like Lisa saying, where a decision has already been made, the pharmacist doesn't know about that. They may not know their blood work and all that kind of thing. One of the reasons, like, I would feel, I'm a pretty, like, fairly competent pharmacist, I'd say, in my area, and I would feel very uncomfortable talking with the patient and helping them to make a decision when I didn't know what their other care providers had talked with them about. Not because I just, I don't want to step on anyone's toes, but because I understand that misinformation, or what can seem like misinformation to a patient, is actually a huge disservice to them. So what I'm trying to get around to is like what you're saying, Della, about the time that it comes in can be really, really important. And maybe just those situations where someone has come with a new prescription, they're not sure what's happened, is just not the, not the time. Or if you develop a relationship with other healthcare providers in your area, where you can say, okay, well, I'm thinking about starting someone with a new medication. Can they come to your pharmacy and talk with you about this? That would be beautiful to me.
Right, yeah, and I think, if you go back, would you mind going back to the decision aid itself? Like just, because looking at the decision aid, you've got to go through all those steps, right? And somehow the patient needs to have an orientation to the aid, and then they need to be able to have a follow-up conversation with somebody. In a lot of cases, the pharmacist could do it beautifully, because a lot of the information on the aid, which is why we liked it so much, is very relevant to pharmacist conversation. But it's weird to insert that in the care process, knowing what the other providers have been doing. And then if the providers already have, most providers are not going to use this kind of decision aid at all, so then they will have had some of the conversation, but could the pharmacist use this as a tool for reinforcement in some way, or for if someone, like you say, is not adherent, not taking, it's had an adverse effect, moving back to what do you think is most important about your care? Yeah.
Did you, and I guess you had such a small number, but I guess I would be interested in the people who are certified diabetes educators and are really seeing a lot of those patients. Like, where do they think this kind of a tool could come into play?
And we had 9 people that were certified diabetes educators, I think, right?
So we asked them where in the process, where in the patient's journey would you implement that? I don't think we didn't ask that question.
Maybe not where, but we would have thought that they would have come up with it.
And it didn't come out. It didn't emerge from the interview data at all.
No.
What did emerge is that there was a lot of similarities, whether or not they were CD or non-CD, about the overall implementation of this decision aid. Like that.
Yeah.
Like the overall use. Like most people thought, this will be great, but I don't have time for this.
I'm not going to be able to do this.
Yeah. I don't have space for this, or
which is not kind of what we were expecting. We really, we all thought, oh, this is great.
This could be amazing.
We could see where it could go. And then the Mayo Clinic folks were really excited to hear about how pharmacists thought that it could be tailored for them. And we're just nowhere near where that is.
We're not ready.
Yeah.
I mean, pharmacists aren't ready.
Not currently in the current space. I mean, I think in different settings, working with the team, they could be, knowing this is what I've had this conversation, and the pharmacist is going to have that conversation, and Sarah or Sherry Lynn, if you guys have any questions, and you can put it in the question pane or any comments, please feel free. I can see that.
Are there any other decision aids that are being used? Like, I'm looking for smoking cessation, or no? Would that be more of a guideline?
We didn't find any. Like, we looked for shared decision making in the pharmacy context. There were none.
Yeah.
What we did find was some decision aids did include a pharmacist in their design, meaning like they had focus groups and there was a pharmacist. But there was I think 2 articles that included one pharmacist in their team of experts. Maybe I think it actually was only one actually. Yeah, so we didn't find any, because I think when you look for tools for pharmacists, you're going to find more like algorithms. That's what
I was thinking of the deprescribing ones. You can work
but they're more like algorithms, and they're not
decision trees. They're not patient focused.
They're not patient focused at all. They're more for the pharmacist. Okay, so what do I have to do? I have this problem. I have to solve it. And I have to give the patient an answer, or I have to give the prescriber an answer. But they're doing it in their own, in their silo. They're just doing it in their own.
Yeah.
And this is more of a collaboration between the clinician and the patient.
I mean, I've used a number of these tools in the clinic that I used to run, which was a complex polypharmacy clinic. So when people were trying to decide if they're going to start on a cholesterol medication, there are some tools, cholesterol, estrogen replacement when we used to use that. I'm old. And, you know, just different tools like that. And so I have used it. They're hard because, and I remember, that's right, the very first estrogen replacement one had an audio tape, if you can believe it. So you would give somebody, I mean, now I guess I'd have to look for the podcast, but you would actually give somebody the audio tape and the booklet, and then they would go home and they would read it through, and then you'd come back, and then we would sit and talk about that. But it was a very intense process to have, you know, so you'd only do that in, well, I didn't think that you'd only do it in specialized situations. We just did it.
Mm-hmm.
But then I thought there could be a lot of application to this process in regular pharmacy practice. But it does take time to coordinate how you're going to introduce this to the patient, what tool are they going to take home with them, and then how are you going to have the follow-up discussion. But really most of the conversation, most of the time is the patient's time, using the tool and going through the tool, which is again why it was all very foreign to pharmacists, so that people couldn't really figure it out. But it is mostly what the patient does on their own, and then comes back and has a conversation.
And I recall one pharmacist saying, like, most of my patients just want me to make the decision for them. Like, they want me, they come to me for advice. Like, oh, I'm the expert, so why am I having these conversations with them? And I was like, oh, wow. Like, you know, because my background is in pharmaceutical policy, and so this, you know, 15 years ago when I started, that was what I was hearing about, patients being involved in those policy realms. And now you talk to people and it's like, of course patients are going to be involved.
Yeah.
And it's like going back 15 years and I'm like, oh, we're still there in pharmacy. Okay. It could have been the age thing, like, you know, like but.
And some of the things, like I think if we had to do it again, some of the areas that we didn't probe, because I you know, we didn't get a lot of conceptual understanding, but the idea that I think this is, you know, only for certain situations. So where it really is high risk, where the decision itself is complicated based on the benefit risk equation. So that I think when we were trying to pharmacist, it was almost very general. So it's sort of like all decisions, but really if we pulled it back and said, okay, there's these really iffy decisions that patients have to make where it's really complicated and it's different. People will weigh off, should I use anticoagulation or not, or should I, although that's less controversial now, but certain decisions that are more controversial or more fraught with differing opinions based on your values and preferences, you know, there might be 10 situations that we could come up with where if pharmacists were really schooled in helping people make educated decisions or being a sounding board for those, then that might be the place to start with this. We kind of chose diabetes because it was complicated, because there were tools available, and we thought most pharmacists would be really familiar with diabetes, but in the end that might not have been the place to talk about this. Yeah. Like these tools really started with atrial fibrillation.
I was just going to say, those were the ones that I used.
Yeah.
And I know you're right. It's like less controversial now, but a couple of years ago, especially when like rivaroxaban and Afixaban came out. So I'd see these patients in Emerge and then GIM who'd just been diagnosed with AFib, and the cardiologist or the staff would be like, hey, Naomi, can you go and spend half an hour and talk with them about it? But I became, okay, it's a small group, like a little bit, not cynical, but like I would use a tool and I would talk to the patients, but I began to realize the hospital setting is just such the wrong setting. It's horrible. They've been through this awful experience. They're stressed. The food's terrible. They're not sleeping well. Someone's next door. And here I am trying to lay all this out for them and help them pick. And in the end, they would often say, well, what do you stand for? And so, which I'm actually, at the time I was less thrilled about. And now as a couple more years on me, I'm like, oh, I understand that. Like I have had a few health situations where actually I do want my doctor to explain things.
Or just to give you their expert opinion, like weigh in.
Mm-hmm. Yeah.
I know, I had that too. I asked the physician, okay, so if you had to, what would, it's like, no, it's your decision. I'm like, no, but like, tell me, like, in your opinion, what's the better option? Yeah. And he's like, I'm not telling you what the better option is. You have to choose. I couldn't believe it. I was shocked. And I just looked at him and I said to him, you're the surgeon. You've been to school for many more years than I have, and you're much more of a specialist in this area than I am. So like, can you give me your opinion? And he's like, no, I'm not gonna. I just weighed it out to you what the benefits are of each procedure. So decide, you have to decide. I'm not going to tell you what to do. And that was the first time I've ever had that.
Yeah.
On the other side, you're the other side now.
Yeah. Really? Wow. I didn't want him. I just wanted to say, like, okay, in my opinion, you should do X, and then I would decide. Then I'd go home and think about it and talk about it. But he was just like, it's your decision.
You have to be like, what would you do for your daughter or something? Like,
I've done that once. Yeah.
So, Sarah has a question. Yeah. Do you think expectations and willingness to use these decision aids from patients might differ from rural to urban settings? Is there research on pharmacist-patient relationships in rural urban settings compared to urban? Which is a good question.
That's a really good question. I don't know the answer to that. Lisa, do you?
I don't know the answer. I don't believe there's any research on it in terms of shared decision making with pharmacists in rural urban. There might be research on it with physicians, but I don't know. But I think that, I think we wanted to
But is
look
she
at.
asking about shared decision making or expectations that patients have? Like maybe they have different expectations.
Patient expectations, willingness to use decision aids. Right. So that's what she's asking more. That's true.
And I think I would guess that probably expectations are different in rural and urban because they just don't have a choice. The pharmacist is probably the only healthcare provider they can see very frequently, and they probably have closer relationships with their pharmacist than they do with their physician. That would be my guess, but I haven't seen.
We don't know, and that's why we asked. That's why we wanted to have the diverse sample was to try to get a handle on that. But we didn't find anything.
In a rural setting, pharmacists might know the other prescribers,
Oh,
and
for sure.
practitioners, and
They're down the street. They'll pick up the phone. They have to
to
because it's such a small community, right?
Sarah says another project for you.
Yeah. Sure. I just need the funding for it, Sarah.
Yes, and there's that small gap that's coming up in your productivity.
Oh yeah.
In one way versus another.
I'm sure I'll be bored.
I don't think so.
No,
that's not true.
Not true. No, my other two I never took mat leave for. I was doing my PhD, so I don't know from this break thing. I never had a real break.
Oh my gosh.
Oh, wow.
Wow. I don't remember I remember thinking I was going to be bored, and I had no brain to even know whether I was bored or not. So there you go. So I think I think this is still really, sorry, I'll take a step back. From the curriculum perspective, it feels like we're not quite there yet to try to figure out what this means in the curriculum. Like I think one of our thoughts was, could we learn something that was going to help with education? But we're still trying to figure out where this is and what this is in practice.
Or if we were prescribing for minor ailments, could this be a way of, providing pharmacists with some tools to make those decisions or help patients make those decisions? Like, it seems more, seems like it would be more applicable at that point.
Yeah, like the prescribing and diagnosing.
Yeah.
That's a good point. I mean, for me, it comes down to patient-centered care, right? So I think when pharmacists are learning about patient-centered care, now I don't know what the curriculum is like in this area, but I would think that this would kind of come as a subtopic. Like, what are some ways we can engage our patients? In addition to like motivational interviewing, which I think there is a component of that. And usually I think it's brought in with the cases. I think this would be like another tool that you could potentially use depending on the situation, depending on the patient, depending on where you're practicing. Like if you're working in a family health team versus a hospital, like versus a community, there may be locations of practice that this type of aid would be more useful for. Like I think actually in a hospital that might, your example was a good example, but I think that in hospitals, when pharmacists are actually part of rounds, this actually might be helpful. Maybe, possibly. I think.
Yeah, I think even the concepts, like starting with what is shared decision making, because I think there's no, those are pretty well recognized. Steps in the shared decision making process. And even if we're not quite sure where we fit in yet, if we have a better knowledge of what those steps are, then we won't just slip to here's a list of your options, sayonara. Like, that's kind of what we do now. You know, here's a whole bunch of options, and we may not fully help the patient.
Yeah, I just had this funny thought. So some of the things that's like very frustrating with students I've seen over the years, whether it's in APPE rotations or residency, is you ask them to make a plan and then come up with some suggestions. And sometimes what they do is they don't actually, I always call it to my students, like, make a choice. So they don't in the end make the choice. And what's interesting with that is if they then have their list of 5 things that maybe could work, really cool, and I don't know how this would work at all, but from an education perspective, is then to add on somebody that would help, or something to help them interact and work with someone to make a decision, because it's a funny thing that has been consistent over like a number of years with many students.
Not to
You
make a
ever talked
decision.
about that?
Absolutely.
Yeah.
Not to make the decision. And in the end, in fact, this whole sort of approach to care, philosophy of care, is you actually don't make the decision as a pharmacist, right? You make it with the patient, or the patient makes the decision, but you're working with them with shared values, or you're sharing your values or preferences, but the patient's able to elicit theirs. So we don't actually, maybe we don't, we want, in some ways we want the pharmacist to be able to make a decision, sort of counter to everything, but we want them to be able to, what we really want them to be able to do is to really understand the differences, and then help understand how different values and preferences would lead to a different decision.
Yeah.
So it might even be that in the cases, maybe that's what we don't do. Do we do that? I haven't done cases. You guys do cases, or you more, Naomi?
Mm-hmm.
Like, do you give a list of the patient's values and preferences as part of the case, not just the clinical characteristics?
Yeah,
And
it's so funny. So we just did an adaptation lab with the 3rd years, and actually there was, like, we tried to include more of those. We had standardized patients. So
Yeah.
the standardized patient know what they're. So sometimes even just silly things like, I'm going on a plane and I don't want to take this liquid for my kid. The doctor prescribed 5 days. Is there any other, like,
Yes.
anything else I can do? So trying to have them realize, oh, there's other options.
yeah,
Yeah, but they have, some of them do really well with it. Other times, it's hard. It's hard.
It's hard. They're
Yeah.
doing it in
But we do
other
try, Lisa. Yeah.
Yeah.
other fields. Like, you know, like this is the thing. Like, they're teaching shared decision making in medicine and in nursing, like it's part of their curriculum.
Yeah.
And if pharmacists want to be part of the club, of the clinician club, then I feel like this is something that should be taught. And maybe it's not something that they need to necessarily implement right away, but they should know about it, because if a patient's coming to them and hasn't had the conversation with their physician, they could also say, like, you know, maybe you should talk to your prescriber about this. Like, this is something you have a right as a patient to go back to your prescriber and have this discussion.
Yeah.
Or if you don't feel comfortable having that conversation, I can call your prescriber and have that conversation. And that's within the scope of a pharmacist.
Yeah.
To advocate for the patient also, right? So I think even if it's, okay, maybe they can't implement a decision aid, but they can still be advocates for their patients. And this is a way to teach that, I think.
Yeah.
No.
Yeah. Really good point. So that's interesting. So and when you put in something in the case, do you put it in the standardized patient guide as a particular?
So we can, sometimes we'll include it as part of a statement they should make if the student says this, or
Yeah.
if they're opening, but we do, I mean, I'm sure I could do it better, especially you're talking to me in the middle of term, so I feel like I can do everything better, but there's absolutely ways to do that, and we do try,
Yeah.
so.
Oh no, of course,
Yeah,
that's good.
yeah.
But I'm just sort of thinking about.
So you can put, I think we have a line for attitudes, values, that kind of thing.
Yes, because I think, if I think back to the SP decision, the guide that I think I'm familiar with in writing a case, there was a time when we had that line in there, you know, as a particular, allowing us to think about that when the patient was coming through. Well, thank you, Zahava, for giving us a chance to focus on this work and have a good discussion about it.
Yeah, thanks, Lisa.
Very appreciated.
Any other questions from
And
Sarah?
yeah, no, I think there's no other questions or comments from Sarah saying thank you. And Sherry Lynn is on as well. So it's nice to be able to hook in with people from Waterloo, which is why we went through the trouble of the technology, which is good.
No thanks, you were our pilot.
Yeah.
For the system.
I'll tell you after that.
Oh, I saw there was a wrench here and screws on the table.
Sherry Lynn saying thank you as well. So thanks, guys.
Thanks, Erlyn.